Hi guys, in this pulmonology section, instead of beginning with traditional data like pneumonia or pleural effusion or pneumothorax, I am deliberately starting with cystic fibrosis because this is a high yield topic. And my previous years of teaching, what I've seen is that these high yield topics are more frequently asked and they are the ones which are commonly neglected as well. And that's the primary reason why we are doing the unconventional approach to start pulmonology section with cystic fibrosis. Well, the alternative name for this condition is to be known by you, that is mucoviscidosis. And the reason why it is called as mucoviscidosis is because the secretions by exocrine glands are much more viscid and thick. In fact, there can be insufficiency of secretions which are produced by exocrine glands. The condition that we're discussing at the moment in the opening line of Harrison is written as exocrinopathy. Why? Because this condition has a tendency to involve mainly exocrine glands. One of the important exocrine glands in the body is pancreas, and therefore pancreatic secretions in this condition or the pancreatic juice which is produced will be thick and viscid. Because it is thick and viscid, it will not be able to come out. There would be local damage in the pancreas. There's going to be fibrofatty deposition in pancreas, and pancreatic juice is not able to come out. And as a result of it, if you do not have pancreatic lipase, then fat will not be absorbed. If you do not have absorption of fat, it will cause steatorrhea. It will cause malabsorption. If amylase will not be absorbed, there would be osmotic diarrhea. So one of the fundamental problems in this particular condition that we're discussing is that the pancreatic function will be hampered, and as a result of it, osmotic diarrhea or failure to thrive would be initial manifestation described in a child presenting with query cystic fibrosis. I said query because we'll have to do a workup of this kid, but I've just given you a heads up for this genetic condition. You are aware that this is autosomal recessive. Now, how in a case-based scenario will he write the word autosomal recessive? He will write child born to consanguineous marriage. Consanguineous marriage would mean marriage between cousins, and you're aware that if there is marriage between cousins, then autosomal recessive disorders will start showing significantly higher presentation in that population per se. And this autosomal recessive condition will have 25% chances of being expressed in the next generation as well. As a result of it, well, the importance is that the question might mention that the elder brother or sister of this child also had same presentation, failure to thrive, pancreatic function getting hampered, and then subsequently child had recurrent pneumonias and expired because of it. So there might be a history given of a child born to consanguineous parents, and the elder brother or the sibling brother or sister of this child died due to similar problem due to combination of GI problems and lung problems. The most important message at the moment is every time you get a question with respect to child with malabsorption syndrome, everybody starts thinking in terms of celiac sprue. So that is a right thought process. Obviously malabsorption syndrome, celiac sprue is obviously to be considered, but at the same time in celiac sprue you're not going to get recurrent pneumonia episodes. So right now I'm giving you heads up that every time a question begins by describing child malabsorption syndrome and adds to that repeated lung infections, you need to keep into consideration cystic fibrosis in the list of differential diagnosis as well. Having said that, let's focus on a bit of genetics because that's the in thing nowadays. So you're aware that this disease occurs due to a defect on chromosome number 7 due to defect of this particular gene that's called as CFTR gene, that is cystic fibrosis transmembrane conductance receptor, and this gene codes for a protein which is again present in the exocrine glands that called as CFTR protein. Now this CFTR protein will be having a total of 1480 amino acids, and what they have found out is that one of the amino acids which is located at 508 mutation happens to be phenylalanine. And majority of cases what we find is, and this is an important aspect from the genetics perspective, that at 508 position in CFTR protein, this phenylalanine amino acid is going to be deleted, and as a result of it, there would be a defective protein present, and this defective protein would then contribute to the lung secretions or pancreatic secretions to become much more dehydrated, thick, viscid, and there would be insufficiency of secretions as well. In some MCQs, he would rather write it in this particular form. He will say what is the most common mutation that would be seen with respect to cystic fibrosis, and your answer would be the most common mutation that is seen is called as F508 deletion. And as I explained to you, the meaning of this word F508 deletion would be that there's deletion of phenylalanine at 508 position. The implication of this is that CFTR protein is produced. But because of this deletion, this would be a misfolded protein, and misfolded proteins would be now begin to get destroyed by the quality control system present in the cells. You're aware that our cells have a quality control system. If we have misfolded proteins, the body will try to destroy it. So therefore, the endoplasmic reticulum present in the cells of the exocrine part of pancreas would now be causing a destruction of this protein. So you can see that the hard work is being done. I mean, the body is synthesizing a protein, but because it is a poor quality protein, because it is a misfolded protein, the endoplasmic reticulum will cause a endoplasmic reticulum mediated destruction of this protein. And therefore, due to the deficiency of this protein, what will happen is that the lung secretions will be thick and viscid. The bile will be thick and viscid. The pancreatic juice will be thick and viscid. Guys, this condition has a tendency to primarily involve the exocrine glands in the body. So all secretions tend to become dehydrated, thick and viscid. Having said that, I would like to, because they've extensively asked about this F508 mutation or F508 deletion that I've explained. So it is no big deal that they would like to ask about a second mutation, which is also documented for this condition, that is G551D. Now what that basically means is that there's going to be a replacement here, that is glycine to aspartic acid replacement. And the importance of knowing this information is, I mean, why is he asking you all this genetics data, is because if it is going to be phenylalanine deletion, then the quality of protein is defective. Misfolded protein, you see, I have taught you misfolded proteins in neurology. Remember prion disease, variant Creutzfeldt-Jakob disease, that is misfolded protein, and misfolded protein is anyway a topic that you study in pathology. So every time there is poor quality proteins being produced, the body will try to destroy them. The problem is body is doing the hard work and then producing a defective protein and destroying it, and as a result of it, the whatever function this protein is supposed to do, which is to keep the lung secretions and the pancreatic secretions and the bile in a liquid consistency, that function would not happen. Therefore, the lung secretions and all these secretions that I'm pointing out are gonna be thick and viscid, and that's why the name of the disease is mucoviscidosis. Now, what they've documented is due to the second mutation called as G551D mutation, where there's a glycine to aspartic acid replacement, there is a defective gating. Now, what I mean by defective gating is that the function of the CFTR protein is to transport chloride and bicarbonate and water. I'll repeat that again. The function of the CFTR protein is that it is responsible for transport of chloride as well as transport of water as well as transport of bicarbonate. And even if you neglect the bicarbonate component, what I would like to draw your attention to the fact that if there is going to be a defective functioning or defective gating, I mean, if the CFTR protein is there but it's not going to function properly, then the chloride values would be impacted, right? You are aware of this condition, and you would be aware of the fact that we do a specialized test for diagnosis of this condition that's called as sweat chloride estimation, and sweat chloride values are always elevated. So I'll also tell you the cutoffs based on the current or the recent updated guidelines with respect to, I mean, what are the diagnostic criteria for this condition. But at the moment, I've said two things. One, CFTR protein is being produced and then getting destroyed. That is one possibility. Or the second possibility is that it is produced in adequate amount. It is not a misfolded protein, but it is still a defective protein, or I can say this is a quality defect. I mean, the second one that I'm describing is again a quality defect, that the transport of chloride, the transport of water is hampered, and therefore what you get is overall secretions which are thick and viscid. Having said that, let me give you a demonstration of this as well. Just a re-emphasis of what I was explaining. Like in our lungs, we have ciliated columnar epithelium. So you can see the cilia. You see our cilia always beat in a single direction. You are aware from basic sciences that what we have is called as mucociliary escalator. Just like an escalator moves in a single direction, the cilia beat in a single direction, and they're responsible for clearance of inhaled bacteria. I mean, India is such a crowded country. I mean, you're taking a flight, you're going by train, you're going anywhere. I mean, there's going to be so much a crowd that you would be literally, I mean, even if you're in a metro, there would be so many people around you, and somebody is coughing, somebody could be having infection, somebody could be having colonization of bacteria in their nose, and they're coughing and they're spitting in front of you. So we all are like inhaling bacteria into our lungs, but then our security system, that is the cilia and the lungs, help in preventing us from getting a lung infection, and therefore we have a mucociliary clearance for inhaled bacteria. But if this mucociliary clearance for inhaled bacteria is hampered, if it is affected, That's when pneumonia will set in. You can see the cilia dipping into this area that's been shown in a slightly dark green representation. This is PCF, this is periciliary fluid. And this periciliary fluid is liquid consistency because of the fact that we are having transporters here, or what we are having here. In fact, let me just represent this here. Let me say this is representation for CFTR, cystic fibrosis transmembrane receptor. The function of the cystic fibrosis transmembrane receptor is that it is responsible for gating, or it is responsible for transport of chloride as well as water as well as that of bicarbonate. And you can see that if I put a cross here symbolically to say that if this is not working, it could be defective gating, it could be that the quality of the protein is defective, so it has been destroyed and it is not there. I said two possibilities. One, the protein is there, but it is not allowing this transport. That is defective gating that I was explaining to you, G551D mutation, or it could be F508 deletion, which will mean that the CFTR protein will not be there, and or will be in lesser amount, and as a result of it, water is not going to move out, and therefore what we're going to get in this condition is that there will be a periciliary fluid dehydration. This is one of the important points which you need to understand for this condition, that because of defective function of CFTR, we are going to have a PCF. PCF means periciliary fluid dehydration, or there's a loss of water content here. Plus, because bicarbonate will also not be transported, there would be an acidic environment also. The combination of the two that are currently written before you, dehydration of the periciliary fluid plus acidic environment, is responsible for a defective or impaired mucociliary clearance of inhaled bacteria, which will explain the fact that why higher incidence of pneumonia is seen in these people as compared to you and me. I mean, even you and me would be exposed to Staph aureus or any other bacteria names that I'll be writing, but because our defense systems are fine. See, here problem is not with like neutrophil function or lymphocyte function. The problem here is per se very fundamental, that if a bacteria comes into the lung, the mucociliary escalator is supposed to help in clearance of this bacteria, but in this case this would not happen, and therefore majority of these cases will be developing the first episode of pneumonia either with Staph aureus or with Haemophilus influenzae. Now, because of the Staph aureus or Haemophilus influenzae pneumonia, the child will require to be hospitalized, and little do we know at this point what is going to happen to this child in future. We will notice that though we have given appropriate antibiotics, we have given appropriate antibiotics in the right dosage for the correct duration for these patients, but the child will be admitted again. So we thought it is one rare event where a child was admitted with diagnosis of pneumonia and then he has come back again after a month or 2 months. But we'll soon realize, if we serially see the repeated hospitalizations of these patients, that this child is having a fundamental problem of lungs not being able to clear the bacteria, and therefore recurrent pneumonia episodes will be noticed. You see, if they change the hospital, if they change the doctor, it's a separate issue, then diagnosis will be delayed. But if they continue to come to the same hospital and you see the record of the patient serially, you will notice recurrent pneumonia episodes. And if anybody is repeatedly hospitalized, he runs the risk of getting an infection from the hospital environment. And that is one of the big problems, because once Pseudomonas aeruginosa colonization of airways will occur, it will contribute to substantial amount of damage to the lung, so severe that it can even cause bronchiectasis. Guys, traditionally, we read about bronchiectasis in adults, but I'm teaching you bronchiectasis would be occurring even in a child because cystic fibrosis has a pediatric presentation. So this would be a child having development of bronchiectasis, which can even cause purulent bronchoria. It can cause clubbing in a child. Again, clubbing is something that we anticipate, adult person may clubbing hoga. But you will get a child with clubbing because of bronchiectasis and recurrent lung damage. And every time there's recurrent lung damage, there can be cor pulmonale, that means right ventricular failure due to non-cardiogenic causes. So one of the biggest reasons why these patients will die is primarily because of the lung infection. And another problem that is still, till now I'm saying bad things, I'm saying even worse than this. What can be worse than everything that I'm saying? Parents have to bring the child for repeated hospitalizations for pneumonia is that this nasty bacteria, when it will colonize the airways, there is a special mucoid form of this Pseudomonas aeruginosa which will now start developing, or which will just adopts a mucoid form. And the problem with this mucoid form is that it exhibits an exoproduct by the name of alginate, and this alginate exoproduct would be something like a biofilm. Now, what I mean by biofilm is like you can imagine this bacteria is having a protective covering over it, due to which the antibiotics would not be able to reach this bacteria. Imagine a bacteria so nasty that it forms a protective shield around it. That's what I mean by the word alginate exoproduct. The meaning of the word alginate exoproduct is that the bacteria is producing this compound which is literally causing something like a security shield around it, which is gonna prevent the antibiotics from reaching, and thereby even if you give the best quality antibiotics in these cases, subsequently once the colonization occurs, I'll teach you strategies to prevent this colonization also. But at the moment, the message is once you get colonization with mucoid form, so Pseudomonas aeruginosa, it's a progressive downhill course. A lot of these patients might be only saved if we go for lung transplantation. Lung transplantation is not a joke, right? I mean, it requires a lot of resources. And even if you do lung transplantation, you would be able to add only maximum 9 years of life to these patients. So as such, I can say the minimum learning for you guys at this moment is anytime that question talks about a child with diarrhea episodes, malabsorption, steatorrhea, okay, you'll think in terms of celiac sprue, but the moment he starts talking about lung involvement as well, you are like alarm bells are ringing, right? And that's gonna be when you're gonna think in terms of, okay, I be thinking in terms of doing a sweat chloride estimation in this case, and should I be doing DNA sequencing so I can pick up the genetic defects here. In fact, one of the best ways for diagnosis of this condition is DNA sequencing. I mean, if we can determine the presence of CFTR mutations, whether it is F508 deletion or whether it's going to be G551D mutation, that is the best way for diagnosis. For initial testing, obviously sweat chloride, that you guys even know. But if he says confirmatory test, then it's going to be mainly answered as DNA sequencing, and I'll subsequently mention the algorithm that should be used for diagnosis of this condition. Let us now focus on the pathology of development of this disease. So as such, because the lungs are involved, you can see in the CT chest of this patient these gross dilated airways, and these dilated airways that are currently marked out are suggestive of diagnosis of bronchiectasis. But the disease does not start off as bronchiectasis. The initial involvement in the lungs is of small to medium airways. So if he says what's the initial manifestation would be the small to medium airways getting involved, and therefore bronchiolitis and bronchitis are relatively early manifestations. But very soon recurrent pneumonia episodes will occur, and as I explained to you, once you have recurrent pneumonia episodes, then Pseudomonas comes in that causes damage to the airways. The damage to the airways now is occurring in the large airways as well. That would be bronchiectasis, and now you could be having complications like even hemoptysis. You could be having even development of clubbing in these patients, and even upper respiratory tract is involved in this condition. So don't be surprised if he mentions regarding sinusitis. You see, sinusitis we read in Kaltenegger syndrome also. But at the same time, sinusitis is present even in patients of cystic fibrosis, because see, in this condition, it's not that the cilia are not able to function because there is a ciliary motility defect. Like in Kaltenegger syndrome, it's a dynein arm which is defective, and it's the cilia that are defective, they're not able to function. Here it is the environment around the cilia, the periciliary fluid, which is the one which is problematic, and as a result of it, well, they're not able to optimally function. So I'll repeat that statement again. Kaltenegger syndrome is a defect of cilia per se. The cilia itself is not going to function. Here it is the environment around the cilia which is defective, which is going to cause an impaired mucociliary clearance. And sinusitis most of the time serves as a reservoir for bacteria, because lots of time the bacteria would be sitting in the upper respiratory tract and gradually would go down and colonize the lower airways of these patients. So lungs are the major reason for the morbidity and mortality of this condition, and then even pancreas would be involved. Now pancreas has an exocrine component, so that's going to be affected, but don't be surprised when I teach you that even the endocrine component is involved, because ultimately there is a fibrofatty damage in the liver. The exocrine component is damaged, that is okay, but when I say the word fibrofatty damage, I mean there's fibrosis, there is fat deposition in the pancreas, so total mass of the pancreas will become lesser. If overall the total mass in the pancreas is lesser, then or the bulk of the pancreas is lesser, then beta cell population will also be lesser. I'll repeat that again. I said if you focus on this pathology word fibrofatty replacement of pancreas, it means total pancreatic mass is reduced. And because of the reduction of the pancreatic mass, you would be having decrease in production of amylase, which is responsible for absorption of sugar, lipase, which is responsible for absorption of fat. So steatorrhea, weight loss are the standard presentations. As I've said, I mean, malabsorption syndrome is what is gonna always start with. But over and above this, I said, because the pancreatic mass is reduced, these patients will also develop secondary diabetes mellitus. So do not be surprised if fasting blood glucose is given to be elevated in this question, or a 2-hour value is given to be elevated in this condition. The reason for that, as I explained, is that later on in this condition, even the exocrine gland gets involved, and we can also find in some cases even presence of insulin resistance. Yes, guys. There are two things I said. One, there is diabetes mellitus developing because overall beta cells of the pancreas are also getting affected. The endocrine component of the pancreas is affected. The pancreatic mass is lesser. But over and above this, I said insulin resistance is also documented to be present in cases of cystic fibrosis. The exact reasons for why we get insulin resistance is not documented. Now, as far as the liver is concerned, one of the exocrine productions of the liver is bile. And in this condition, the bile is going to be thick. So it's gonna obstruct the intrahepatic biliary ducts, and therefore there would be cholestasis that can cause obstructive jaundice. And in the later stages, the same case can start developing secondary biliary cirrhosis. I said initially there can be obstructive jaundice, but in the later part there is secondary biliary cirrhosis. At this moment, I would like to just state a general MCQ, which you are aware that we have a condition called as primary biliary cirrhosis or primary biliary cholangitis, for which there is a specific antibody that is usually asked in your exams, a one-liner MCQ, that is AMA, that is anti-mitochondrial antibody. But at the moment, I'm talking about secondary biliary cirrhosis that is seen with respect to cystic fibrosis. So obstructive jaundice will cause cholestasis. Pruritus and jaundice are the manifestations. Mustard yellow discoloration of urine would be present. And if there is going to be cirrhosis, then the bad news is that there can be portal hypertension, splenomegaly, ascites, caput medusae developing in these patients as well. The main reason why this is happening is because of the fact that intrahepatic bile ducts are blocked. And the reason for this intrahepatic duct blockage is a thick bile. It is a viscid bile in this condition. As I've explained, this condition, the first line I said was mucoviscidosis. So there is insipidation, the bile ducts are getting blocked by a thick bile, and this subsequently causes development of secondary biliary cirrhosis. After lungs, pancreas, and the hepatobiliary system, the next thing to be involved is the genitourinary involvement, and this is again quite frequently asked because he would love to know regarding the infertility component. Well, yes, we get infertility in these patients. Majority of male patients, he says about 99% patients of cystic fibrosis will be having infertility. They would be having azoospermia. Now, this is in contrast to Carter-Neger syndrome, where there can be infertility because of defective sperm motility. But here I'm not saying that sperm motility is defective. Here there is primarily azoospermia, and there are two reasons why there can be azoospermia in this patient. One is that there could be impairment of the epithelial function. You see, CFTR is present everywhere, so there is an impairment of the epithelial function of vas deferens. That is one explanation for why do we get azoospermia in these patients. The second reason is that some percentage of cases of cystic fibrosis can be even having a agenesis of vas deferens. So due to, he says there are two primary reasons. One is going to be agenesis of vas deferens. Second is that agenesis means developmental defect, or there is going to be impaired epithelial function of vas deferens, and the combination of the two explains why there is a azoospermia. Then would we have infertility in a female patient with cystic fibrosis? Then the answer is yes as well as no, because some cases may not be having infertility, some cases might be having. That depends on the cervical mucus plug, because you see on the 14th day of ovulation we have spin barkete. That spin barkete is the thin mucus which is released, and that's the time when optimally, sexual activity would result in development of conception, because 14 days when ovulation is occurring. But in a woman with cystic fibrosis, provided she reaches up to that age where she can be a mother, like I said, in India most cases will die because of pneumonia or will die because of malabsorption syndrome. But like in Western countries where they take good care of the lung function, then these patients may conceive. Thick cervical mucus is present, so per se with artificial reproductive techniques these patients can become pregnant. Generally speaking, if a cystic fibrosis patient wants to conceive, what you let her conceive, your answer would be that yes, you will tell her, yeah, you can. She's having so many problems, no? So I need to tell her, is it safe to be a mother? I'll tell her, ma'am, that the decision whether you can be a mother or not is not based on whether you are having a thick cervical mucus. We can bypass the cervical mucus, right? We can go for artificial reproductive technology, and we can tell her, ma'am, that it is dependent on your lung function. Obviously, if she wants a surrogate mother, then things are totally different. But if she wants to carry the baby by herself, if she's having a substantial lung damage, if she's already having bronchiectasis, her lung is damaged, because see, pregnancy increases the work of breathing. If she's having a substantial lung damage, her FEV1 is reduced, because primarily in this condition there can be obstructive lung disease developing. So we would decide whether it is safe for her to be a mother or not based on her FEV1 value. This, what I said, was more of a generic information. This is not going to be asked to you in the exam, because why I'm telling you this is just to sensitize you to the fact that most people straight away say that okay, because it is thick cervical mucus, तो इसका मतलब every female of cystic fibrosis will be infertile. No, that is not the case. Even with thick cervical mucus, possibility of conception is very much there. It is males who are having predominant infertility. So males with cystic fibrosis are going to be infertile, but in female patients there is going to be possibility of infertility, yes and no as well. This is in contrast to Kaltenegger syndrome, where there is going to be issues with infertility for both the genders, but in cystic fibrosis it's going to be mainly male infertility that is present. So most of the time the question will begin by describing CSF. I think I have said this multiple times. I'm just putting up a quick mnemonic for you for that case-based scenario. Most MCQs are going to talk about CSF, which would mean that this is going to be a child who will be having productive cough and might have been admitted in the hospital multiple times previously. Along with that, there might be fat malabsorption, which will be written as steatorrhea, and because of this steatorrhea, there would be failure to thrive. In Western countries, the incidence of babies with cystic fibrosis, developing these clinical manifestations, they identify this in advance only. How can you identify that in advance? You can identify that in advance by going ahead with neonatal screening. So especially in Western countries, we go ahead with neonatal screening. You see, you are aware for neonatal screening is available for phenylketonuria, it's available for galactosemia, it's available for even hypothyroidism. Especially in areas of iodine deficiency, we do a heel prick test. I hope you remember that dried blood heel prick test is done. So in the same spirit, I'm saying that we have a neonatal screening available for cystic fibrosis also. What you will do in this particular case is that you will take blood, heel prick, or you can do a venipuncture, and this dried blood would then be checked for immunoreactive trypsinogen. You see, because the pancreas of this patient is damaged. Therefore, due to the damage of the pancreas, trypsinogen would come in the bloodstream of these patients as well, not trypsin, the inactive form, trypsinogen. So immunoreactive trypsinogen, which is written in MCQs usually as IRT, is one of the tests which can be done for screening for cystic fibrosis. What is mentioned in the current edition of Harrison is that incidence of severe lung manifestations in cystic fibrosis have now become lesser because of these neonatal screening programs which are available. In neonatal screening programs, we can screen for phenylketonuria, we can screen for galactosemia, we can screen for endemic cretinism, that is hypothyroidism, which could be causing delayed social smile, it could be contributing to mental retardation in a child. So there are multiple programs in Western countries to prevent, all those nasty ones like phenylketonuria to have a full-blown mental retardation in future. In the same spirit, we now also have IRT, immunoreactive trypsinogen, on a dried blood sample of a neonate, and this helps us in early identification of cystic fibrosis so that these extensive manifestations that we have seen would not develop. Let's now focus overall on the clinical features. This is more of pathology, so I'll focus now on the clinical domain. How a question would be given to you in case he gives a proper 3 or a 4-liner question. One of the early clinical features which is seen in this condition is meconium ileus. You're aware that meconium is the first stool of the baby and it should ideally be passed within 24 hours. You see, meconium in majority of cases should be passed within 24 hours. Upper limit of passage is obviously 48 hours, but majority of children, it should be passed within first 24 hours only. Now, if a child is not going to pass meconium, you're going to think in terms of conditions like anorectal malformations, like anal atresia. But if it's not going to be the case, then you will think in terms of Hirschsprung's disease. If it is not anorectal malformation or Hirschsprung's disease, what you should consider is the topic that we're studying, that is cystic fibrosis. Guys, meconium is the first stool of the baby, and it is, almost semi-liquid or liquid consistency. Baby was inside the mother for so long, so meconium should have solidified, but it did not solidify because pancreatic juice, the secretions and the enzymes in it keep it in a liquid consistency. Because in cystic fibrosis, the pancreatic juice is thick and viscid, it would not reach up to the meconium, and therefore the meconium is not in liquid consistency and causes development of paralysis of the gut because it can't be passed out. So meconium ileus, the clinical presentation, I mean, he may not write the word meconium ileus because again, you read that in pediatrics, so he knows that you'll be able to solve and think in terms of cystic fibrosis. So he might just say delayed passage of meconium was present in this particular child right at birth, and therefore the pediatrician had to go in for a gastrogafin enema. You're aware that the best test for diagnosis of this condition is a gastrogafin enema, and that can help in even the expulsion of the hard fecal matter as well. You are also noticing that initial presentation of these patients is meconium ileus, but later on the same case will start developing steatoria and steatoria and diarrhea. That's because of the pancreatic amylase and lipase being lesser. Now we have discharged the child from the hospital after treating for meconium ileus, and later on the child would be readmitted once again. The reason for that would be mainly a pneumonia episode, and we will then notice that the child will be having multiple episodes right in the first year of life itself, that is recurrent pneumonia episodes. Because of the recurrent pneumonia episodes, there would be damage to the lung, and therefore this child will develop bronchiectasis, and therefore subsequent manifestations would be described in the form of purulent bronchoria, development of shortness of breath. In fact, in some cases, the damage in the lung can be so extensive that there could be worse sudden deterioration of these cases. Every time you read cystic fibrosis patient is having a sudden deterioration, what you should consider secondary pneumothorax. You see any person having a pre-existing lung disease, if there's a sudden deterioration with drop in oxygen saturation, you have to think in terms of possibility of secondary pneumothorax. Just like if somebody is having COPD, somebody is having staph aureus pneumonia, somebody is having post-COVID, he recovered from COVID, but then there was a deterioration. That's not that he got COVID again. That is what people were thinking. No, somebody with COVID has recovered and then again suddenly deteriorated. It was COVID-induced damage to the lung causing bullas, blebs, and then bullas will burst, and that will cause pneumothorax. Bullas are seen in COPD emphysema, okay, but bullas can be seen after COVID also. They can be seen after ARDS also, and similarly here, because the lung parenchyma is damaged, so secondary pneumothorax can be a manifestation. And because I was describing destruction and dilatation of the large airways, so even hemoptysis will be present. Initially, well, with pneumonia, I'm not saying hemoptysis, I'm saying the same case when followed subsequently, then lung is one of the important reasons for morbidity and mortality of these patients is because of the aspects that I've currently explained to you at the moment. Plus there would be GI manifestations. So how will he write that terms? Like most of the time he will say bulky, foul smelling stools which are difficult to flush away. And then he will also mention regarding features of fat soluble vitamin deficiency. You're aware that vitamin A, D, E, K are fat soluble vitamins, and in the MCQ he can mention regarding easy bruisability, because see, vitamin K is responsible for gamma carboxylation of clotting factors like 2, 7, 9, 10. So because there's gonna be easy bruisability of 2, 7, 9, 10, therefore vitamin K deficiency would be present, and vitamin K deficiency manifestation would be present, and that is why even purpuras could be described in these patients. Vitamin D deficiency will contribute to bone pain in these patients because of osteomalacia, and along with steatoria, he might just write malabsorption, or he might just say failure to thrive, and then he was, after saying failure to thrive, FTT, because instead of writing protein energy malnutrition, he's going to write the word FTT, that is failure to thrive. Meaning of the word failure to thrive is failure to gain weight, because PEM is a very appropriate term which is due to caloric deficiency in poor families. I mean, PEM is a disease because I can say when a child belongs to an economically weak family where is not getting sufficient amount of carbohydrates. That is why you read about marasmus and kwashiorkor. But here, like, this kid could be born to a economically well-off parent. Like most of the time, this disease would be seen in Caucasians. or it would be seen in North Americans. So mostly, I mean, this disease is more common in Western population as compared to Indian population. In fact, the prevalence of this disease is 10 times higher in European and American population as compared to Indian population, and these patients will start developing fail to thrive. Then there would be subsequent liver cirrhosis developing. So how will he describe liver cirrhosis in a question? He might write features like ascites or a splenomegaly that might be noticed. Even caput medusae can be described, because every time there is a liver cirrhosis, the portal vein pressure rises, and that is why portal hypertension manifestations I have described here. Most patients in India will not reach up to point number 5, though I'm writing it from the Western perspective that there would be infertility present. And then point number 6 that I described is again an important one from the perspective of sweat. Now, India is a very hot country, so we keep on sweating. And especially after rainy season, when there is a lot of humidity, then the sweat also does not evaporate, and that is where skin infections, etc. can come in. You see, sweat will be having water, and along with that it will be having salt, that is sodium. It will also be having chloride. So one sweat would be having both water as well as sodium and chloride. In a hot Indian summer, if you are sweating very profusely and you're losing a lot of salt also, then there can be muscle cramps developing. Lots of time in a cricket match, maybe if it is in Sharjah cricket match being conducted, or in Abu Dhabi, in a stadium where there's no air conditioning because these countries are very hot. So a person or athlete can end up with development of muscle cramps. And even if you have, participated in a college football match or a cricket match, if it's so hot and you're playing, you are bound to feel tired and you tend to get muscle cramps. So that is like a normal phenomenon, that sweating excessive amount causes loss of water as well as depletion of sodium and chloride. What I want to tell you is that yes, our sweat will be having sodium and chloride, but it is in limited amounts. You see, sodium and chloride is present in the sweat in a normal person, but it is present in limited amount. And why is that so? Is because there is again that CFTR protein present, which is responsible for reabsorption of sodium and chloride. Why the body is trying to do this reabsorption of sodium and chloride is mainly to ensure that only a limited amount of salt and chlorides, a limited amount of sodium and chloride is lost. I repeat the statement once again. Guys, in our skin, we have, with respect to the sweat glands, presence of CFTR again. And the function of this is that it will limit the amount of salt and chloride that we lose. So you can see that chloride will be reabsorbed like this back, and even the salt will be reabsorbed like this back. And I'm now putting across to say that if there is going to be, defective genes present, due to which defective proteins were being produced, misfolded proteins, or like proteins were being produced but they're not doing proper gating, the transport is affected of sodium and chloride, then the sweat would be having higher concentration of chloride and higher concentration of sodium. As a result of it, people with cystic fibrosis, compare with normal person, a person with cystic fibrosis would be having higher concentration of water, will obviously be present in sweat, but the amount of sodium and amount of chloride in the sweat of a cystic fibrosis patient is higher than you and me. Please appreciate this concept, that the amount of sodium and chloride in a sweat of a cystic fibrosis patient is higher than as compared to you and me, because the CFTR is malfunctioning, and therefore this reabsorption of sodium and chloride is not gonna occur. Now, if you place a cystic fibrosis patient in a very hot environment, like a cystic fibrosis patient is born in India or Pakistan or subcontinent, Indian subcontinent, where it is so hot, or maybe in Emirate side. I mean, Emiratis are obviously more rich and they have access to air conditioning. But I'm saying, let me say a child who's born in a poor family and he is in a very hot environment, then he's going to lose a lot of salt and water from the body. Because of the excessive loss of salt from the body of this person, there would be increase of aldosterone production from the adrenal gland of this person, because every time we lose salt from the body, there is a corresponding increase of aldosterone. And what does aldosterone do? It will try to reabsorb, it will try to compensate for the loss of salt from the body in the sweat. I'm not talking about loss of salt in the form of in loss of salt in the urine. Like, if you listen to my kidney discussion, I've taught you Bartter syndrome, Gitelman syndrome. In Bartter and Gitelman syndrome, I talked about salt wasting. So salt is lost in the urine. But here I'm saying in cystic fibrosis patient, whenever he or she is in a very hot environment, he will obviously sweat more than as compared to you and me. I mean, a normal person also will sweat in a hot environment. But when he's sweating in a hot environment, he would be losing higher amount of salt and chloride from his body. That is because the CFTR, which is responsible for reabsorption of sodium and chloride, is not functioning. Now, because aldosterone kicks in, aldosterone, what does it cause? It causes reabsorption of salt and water. That is good news. It will try to counterbalance the loss. But the bad news is you will also start losing potassium as well as hydrogen. And because of the loss of potassium, I'm writing the word hypokalemia. Because of loss of hydrogen from the body, you guys tell me, what will loss of hydrogen from the body cause? Loss of hydrogen will cause metabolic alkalosis. So what I have tried to explain to you on this slide, though it took me one whole slide to explain, is that patients of cystic fibrosis would be having hypochloremic, because chloride is being lost in the sweat of this patient, hypokalemic metabolic alkalosis. Let's do a quick recap of this in next 30 seconds so that you can just get this imprinted into your brain. Message number one is, in you and me, sweat will be having water plus little bit of thoda sa sodium, thoda sa chloride. Why the thoda sa sodium, thoda sa chloride is because there is presence of CFTR even in our sweat glands that reabsorbs the chloride and reabsorbs the salt. Here, because the CFTR is not functioning, therefore person of cystic fibrosis tends to have more salt and chloride in the body. This explains why in historical perspective, children with cystic fibrosis were called as, or cystic fibrosis in earlier times in textbook was written as salty baby syndrome. Why salty baby syndrome is primarily to say that when the mother will kiss the forehead of the child, she will notice that her lips are becoming salty because the child's sweat will be having higher concentration of sodium and chloride as compared to you and me. And if this patient is put in a hot environment, like in a hot Indian summer without any air conditioning, this child will develop what I've described here, hypochloremic, hypokalemic alkalosis. In the MCQ, it will just be one line. But I've tried to explain why do you read about metabolic alkalosis. A query of a lot of people is, sir, there is a lot of sweat from the body, so that should be causing metabolic acidosis. No, metabolic acidosis occurs due to circulatory failure like shock. If somebody is having diarrhea, which is very severe that it causes circulatory failure and pulses are not palpable, if you are having severe diarrhea causing a circulatory collapse, hemodynamic instability, that is when you get metabolic acidosis. But in this particular case, because there is loss of salt, there is going to be corresponding aldosterone release, because every time you lose salt from the body, the RAS system is activated now, and the RAS system, what does it do? It tends to reabsorb salt and water for compensation. That is good news. The bad news is there would be exaggerated potassium loss and hydrogen loss, which explains hypochloremic, hypokalemic metabolic alkalosis encountered in patients with CF. Now, based on this information, we're gonna be in a comfortable position to study the diagnostic criteria for this condition. The diagnostic criteria are that there should be at least one or more of phenotypic features that I've explained to you. All the clinical features that I was enumerating in the previous two slides are the ones that I'm talking about. Any one of these could be present: lung involvement, pancreatic involvement, hepatobiliary involvement. Mostly will be a combination of lung and pancreatic involvement. Other possibility could be that in the MCQ there could be mention of a similar illness. He may not write the word cystic fibrosis, because if you write CF, then what is the point of asking everything? So he might mention nature or similar nature of illness present in a sibling, brother or sister. Or like in Western countries, there might be a positive immunoreactive trypsinogen, there might be a positive neonatal screening. In India, obviously this would not be valid, but still from the Western perspective, positive neonatal screening can be present. That would be that we will be doing a heel prick test, or we can do a proper venipuncture. We can take a dried blood, and on this we'll go ahead with a test called as IRT, that is immunoreactive trypsinogen. So from this particular side, one on the left side of this vertical line that I put, any one feature can be present. I repeat once again, I'm describing a table before you. in this table, at the moment I filled up only one side, and what I'm saying is that any one of these could be present. Any one of these moved, at least one or more clinical feature should be there, or there should be mention of similar illness in sibling brother or sister, or there should be positive neonatal screening. Any one of these can be present. And then let's look at the right hand side of the table as well, where it talks about the traditional data, which what I say next, I think most of you are like very well familiar with, because all of you read this even in other classes as well with respect to sweat chloride values. You should be aware of the fact that sweat chloride values would be more than 60 milliequivalents, and this should be demonstrated on at least two different occasions by two different lab reports. I mean, we just want to make a double sure. So it's like two different laboratories or two different labs that are into two, basically means it could be like two different reports from two different standardized labs, just to improve the quality control perspective, so that one lab is, if making a mistake, maybe the second one might help us identify. And lots of time there could be like equivocal reports also, like one lab could be saying 40, another one could be saying 65. Now you're stuck. Should I believe the first report or should I believe the second report? It says at least get two of them done, and supplementing this sweat chloride would be the second test, which I was saying was DNA sequencing, where we can go ahead with identification of CFTR mutations. In fact, in the current edition of Harrison is mentioned 6 classes. I'm going to teach you those 6 classes of CFTR mutations as well. So we'll study regarding that there could be defective gating, there could be defective conductance, there could be increased turnover, there could be misfolded proteins, as I was teaching you. So there are 6 classes that I'm going to be discussed subsequently. But at the moment, if they just say that what is the best test to confirm the diagnosis, what is the investigational choice, then it's going to be identification of CFTR, at least 2 CFTR mutations by DNA sequencing. And initial test that would be done, which is highly specific, is sweat chloride. I've written specific, I've not written sensitive, because they can be false positive sweat chloride also. I'll tell you those conditions in a while. Let me finish the table where we get a false positive sweat chloride. And at this moment, guys, stop looking at the notes and let me know, how do you produce sweat in a child? If it's gonna be adult like you and me, we can do hard exercise, running on a treadmill, and and air conditioning is switched off, we'll start sweating. You can't make a baby do exercise, right? So how do you produce sweat in a child? Yes, guys, without looking at the notes. I gave a pause in between. I was waiting for your answer. I know it's a recorded class. I'm just trying to give a semblance of a live one, right? In case you come and see me sometime on a live class, at least come and see me when you clear the exam. Okay, sweat chloride is gonna be demonstrated by applying a chemical on the skin of the child. You're aware that the postganglionic fibers of sweating are cholinergic, no? The postganglionic fibers related to sweating are cholinergic. So we're gonna artificially induce sweat by applying pilocarpine on the skin. I mean, traditionally you read about pilocarpine in ophthalmology, right? But today I'm applying pilocarpine, and then whatever sweat would be produced, this would be subjected to electrical charge to determine the anions that are present. So pilocarpine iontophoresis. And as I explained, this sweat chloride is elevated because CFTR in the sweat gland is not functioning, and therefore as a result of it, the sweat has more salt and has more chloride. Because it has more salt, I will say one more interesting feature here, that if the sweat will evaporate, I mean, cystic fibrosis, what I'm saying next is actually given in Nelson. This is not given in Harrison, the one that I'm writing in green. This is frosting of the skin. What I mean by frosting of skin is कि जब sweat सूख जाएगा, when the sweat is gonna evaporate, that's when the salt will be deposited on the forehead of the child, like whitish deposit of salt on the forehead of the child. And that is why I was saying now, when the mother will kiss the forehead of the forehead of the child will be salty, and that is why they call it in older books as salty baby syndrome. I mean, that's an unofficial term. You are not going to use that salty baby syndrome in your exam or in your clinical practice. But this frosting of the skin and salty baby are like, terms which are mentioned in pediatric books. So I thought I should just share them with you. And then in case the above 2 tests are turning out to be equivocal, I mean, he says if the above 2 tests are not confirmatory or they are not giving proper report, then what are you going to do? Then you're going to go in for a third test, which is very peculiar. And you read this only one in your career, that is diagnostic nasal. It is written as transepithelial nasal potential difference test. So, I mean, this is not a very routine thing, but then you need to remember this diagnostic nasal potential difference test is useful for diagnosis of this condition. And when would this test be done? If the above 2 tests in the column on the right hand sides are equivocal, like both the labs are giving a report of 40, another one is giving a report of 55. So you're like stuck because 60 is the threshold that you wanted. And over and above this, I said that even CFTR mutations are not getting detected, but clinical profile is very much present. So he says that then you can be doing the following tests, which I mentioned, enumerated before you. The total of 3 aspects on the left hand side, 3 aspects on the right hand side. For the right hand side, he also says the same thing, that any one should be present. So the basic point is, for diagnosis of this, you need at least 2 pointers. What I mean by 2 pointers is, for example, there is similar nature of illness in a sibling brother or sister who expired. And in the current case, we have documented sweat chloride to be more than 60 on 2 occasions. Or let me say at least one or more like this is the firstborn child and he's not born abroad. If he's born abroad, then neonatal screening. If he's born in India and he's having recurrent pneumonia episodes, and when I did a workup of him, I found that there was CFTR mutations present. So it's again 2 points scored. So it's anyone from the column on the left, anyone on the column from the right. And that's when we make a diagnosis of cystic fibrosis. And now comes the aspect of sweat chloride, because sweat chloride can be false positive as well or can be false negative as well. So let's just make a list of few conditions where we might be having false positive sweat chloride. One of the conditions is seen in young teenage females who would be having body dysmorphic disorder, that is anorexia nervosa, where sweat chloride values can be elevated. Then another condition which is due to either autoimmunity or due to tuberculosis or HIV, that is Addison disease, can also be having elevated sweat chloride values. Then is CAH, congenital adrenal hyperplasia, and nephrogenic diabetes insipidus. Now, why is it happening in these conditions? I can go into the logic of them also, but then that would not add any substance to solving multiple choice questions per se in the exam. So I am not going into the logic behind why are we getting it elevated in Addison or in congenital adrenal hyperplasia, but each of them has a documented reason. Similarly, when it comes to false negative sweat chloride, there are 2 reasons which could be remembered. One is malnutrition, and you can understand that patient of cystic fibrosis will also be subsequently developing malnutrition. Malnutrition and edema are 2 situations where we can get a false negative sweat chloride, and therefore though sweat chloride is like being used for ages altogether by pilocarpine antiphoresis for diagnosis of this condition, he has said that it is one of the initial tests that you would be doing, and this can be supplemented by doing a CFTR mutation, and the entire diagnostic criteria or the diagnostic criteria algorithm is what I have tried to explain before you at this particular moment. Other tests that I'll be writing for these patients over and above the ones that I've currently discussed would before you is like pulmonary function testing, because I want to pick up obstructive airway disorder. I will also do a HRCT chest to demonstrate that, okay, is it bronchitis or is it bronchiectasis, because bronchiectasis would be usually a late manifestation and that can have severe ramifications in the form of development of hemoptysis, and even possibly even clubbing will occur in these cases subsequently. I will also be doing glycosylated hemoglobin in these patients, because as I explained, diabetes mellitus will occur because the endocrine component of the pancreas is getting impacted. Then we will also be doing a sputum culture. It is of importance to do sputum culture because I would like to select the most appropriate antibiotic based on culture sensitivity report and give it to the case to cause a complete eradication of infection. And in spite of that, these patients will still have a recurrence because, as I said, it's not a disease of the immunity. Immunity is fine, neutrophil count is fine, lymphocyte count is fine, the killing power of the neutrophils, white blood cells is perfectly fine. But that basic aspect that I told you, periciliary fluid dehydration, or the concept of bile being thick and viscid, I mean, those are the viscidity is the word. I mean, the core concept behind this disease is what I said right in the beginning, mucoviscidosis and exocrinology. If you get those 2 points imprinted in your brain, you are sorted as far as this particular table is concerned. Next is molecular genetics, where I'll describe various categories of CFTR mutations before you. There are total of 6 classes, which I'll be explaining. And out of these 6, I would like you to first note down that the most common class of CFTR mutation is class 2. At this junction, I would also request you to stop using printed notes for this particular section of the video and take on a stick-on pad and practice this with me, because otherwise it's not practically possible to remember these 6 categories that I'll be describing before. And well, the full form of CFTR would be cystic fibrosis transmembrane conductance regulator. And the main function of this, as I explained right in the beginning of this video, was that cystic fibrosis transmembrane conductance regulator is responsible for transport of chloride and bicarbonate and water. And one of the most important things was water, because that was keeping the periciliary fluid in its liquid consistency, and therefore the cilia could beat properly. And if this transmembrane conductance regulator will not function, then the water in the periciliary fluid is not there and the lung secretions are thick and viscid. Now class 1 and class 6 पहले note करना है. In class 1 there would be complete absence of cystic fibrosis transmembrane conductance regulator, and therefore you can see that if it's not going to be there, that transport of water is going to be impacted, and therefore periciliary fluid is going to be dehydrated. In class 6 what's going to happen is that CFTR will be produced, but then after getting produced it will be destroyed also much more faster, so there is a accelerated turnover. What is the difference between class 1 and class 6? In class 1 the quantity problem is there, it is not produced at all. In class 6 also it's a quantity problem, but in a sense that it is produced but then is destroyed, so accelerated turnover. Now compare this with class 2, which is the quality problem. 1 and 6, I can, just to explain this, I can say are related to quantity, that either it is not produced or it is produced and it is destroyed. But 2 is going to be related to quality, that a poor quality CFTR is being produced at the moment. So this would be written in the book as defective maturation, but the meaning of that would be what I explained right in the beginning, that there is a misfolded CFTR protein being produced. Like, misfolded proteins, whenever they're gonna be produced, the body's quality control, the cell would have quality control, it will try to destroy that misfolded protein. So there's a defective maturation, and along with that there is also an increased clearance or a premature degradation as well. As far as point number 2 is concerned, you see this will sound a little difficult to remember, defective maturation and premature degradation. So what you're supposed to remember is that this is a quality issue, that misfolded CFTR is being produced. So now out of 6 you are remembering 3, that is 1, 2 and 6. 1 is, and these are the mainly 3 that you need to remember. I'll add up more data, but first and foremost is 1, there is less production. 6, it is produced but is destroyed. And 2, it's a quality issue, that there is a misfolded protein. That's what he means by the word defective maturation, and that's going to be degraded by the endoplasmic reticulum. Then as far as class 3 mutations are concerned, there is going to be disordered gating. And this disordered gating is what I explained with respect to the fact that though the CFTR is present, but it will, this CFTR protein, it utilizes ATP, and that ATP is then used to facilitate the movement of chloride and water and bicarbonate. I repeat the statement again, CFTR uses ATP to transport all of them. Here CFTR is present, but it is not able to utilize that ATP. That is meaning of the word disordered gating, is that it is very much present, but at the same time it is not able to utilize energy. ATP is also there, but at the same time ATP is the energy currency of the body, but ATP is not being utilized by this CFTR. So there's a diminished ATP utilization, and this is due to primarily because of G551D mutation. Class 2 that I've described is that F508 mutation deletion, and G551D is the class 3 that I've described. For 4 and 5, I'll just say that there can be defective conductance, which again implies that there is going to be impairment of movement of chloride across the channel, and that explains why sweat chloride in these patients would also be affected. This defective conductance is via the ion pore. I mean, the pore or the hole which is present will not allow the chloride movement. And as far as 5 is concerned, what I can say is, again, this is a condition where there's a reduced quantity. I'm not saying total absence. 1 was complete absence, but in 5 it is reduced quantity. So let's just analyze the data, guys. Out of this, I would suggest you to be very thorough with respect to at least 2 and 3 at the moment. Let's practice them here. 1 is gonna be complete absence of CFTR. 6 is gonna be कि बन के टूट गया, तो क्वांटिटी का पंगा हो गया, क्वांटिटी का इशू हो गया. Even 5 में भी क्वांटिटी है, but it's not gonna be complete absence of quantity. It is reduced quantity. So 1, then 6 and 5. 1, 5 and 6 are related to quantity. 2 is related to quality. 3 is related to inability to utilize ATP. Whereas with 4, it is not, the problem is not with respect to ATP utilization. ATP is very much there. CFTR is also there. But in spite of that, that movement of ions is not happening. That would be class 4. So the total 6 varieties of CFTR mutations which have been described in the textbook, for which, as I've explained, 2 and 3 are the ones which are to be given a priority. And having said that, we'll now focus on the treatment of this condition. Coming to the treatment of this condition, we need to remember triple combination therapy, which is written as TCT. Before I mention the name of the drugs here, I would just like to draw your attention to a similar sounding term by the name of triple therapy. I have taught you triple therapy for one Helicobacter pylori in the GI perspective when I have talked about Helicobacter pylori in peptic ulcer. And here we use 2 antibiotics, that's clarithromycin and amoxicillin with proton pump inhibitor. You no need to note it down, you already know that. And then triple therapy has also been discussed with respect to rheumatology and rheumatoid arthritis, where I've described 3 drugs, no, hydroxychloroquine, sulfasalazine, and methotrexate. Methotrexate, you are aware, is the major disease-modifying anti-rheumatoid drug. So triple therapy is read by us for 2 conditions, H. pylori and rheumatoid arthritis. But today I'm teaching you triple combination therapy. In triple combination therapy, you need to remember 3 alphabets, that is ITE. The first drug that was introduced for management of this condition for modulating the disease process was ivacaftor. Now, what does ivacaftor do? Ivacaftor is basically a potentiator of gating. You see, just a few minutes earlier, I was teaching you guys that there is a class 3 mutation present in cystic fibrosis where CFTR is present, but it is not able to bind to ATP. And because of that, it's not able to transport chloride and water, and therefore, the periciliary fluid would be dehydrated. And now what I'm saying is that the objective of developing this drug, why did we put a lot of research and development R&D, was mainly to overcome the disability with respect to CFTR protein, which is caused by G551D. That was the substitution with respect to glycine and aspartic acid. But the main concept is that this molecule will modulate the disease process by now increasing the process of gating with respect to the transport of chloride and water and bicarbonate. In contrast, the second molecule to be remembered here is tezacaftor, T-E-Z-A, tezacaftor. This is a corrector of misfolding of proteins. Remember, I told you right in the beginning and even in the middle of this video that the quality of protein is defective and therefore it will get degraded. So that misfolding of CFTR that is occurring, we are trying to correct that by using a molecule called as tezacaftor, and therefore the R&D, the research and development team, basically focused on overcoming the disability with respect to this disease. And if CFTR is not working, it's a disability after all. So to overcome the commonest mutation defect, that is F508 deletion, we are using tezacaftor, and for overcoming the G551D mutation, we are trying to use ivacaftor. And the third molecule that is used here is elixacaftor, not Alexa, wala, ALXE, it is ELXE, elixacaftor. So ITE, let's practice it. Ivacaftor, tezacaftor, elixacaftor, 3 drugs which are used in triple combination therapy, and this is called as a highly effective modulator treatment. We're trying to cause a improvement. Once these drugs have been used, there has been a dramatic improvement in FEV1 of these patients. There is a dramatic reduction in the exacerbations. There is a dramatic reduction in the recurrent hospitalization rate for these patients, because traditional measures we will obviously use. We will talk about antibiotics for these patients. We will talk about nebulization with tobramycin, aztreonam for these patients. Obviously, antibiotics will play a role, but we needed specific drugs that can reduce the disability caused at the level of the lungs, disability caused at the level of the lungs, disability caused at the level of the pancreas or hepatobiliary or other systems that have involved, mainly the lungs part, and that would play a significant role in reducing the morbidity and mortality. Now, apart from triple combination therapy, there are a couple of other strategies that we also need to study. Next, what I say before is more of generic information, but we'll still practice it, which would be that I'll be using an aerosol of DNA ACE in this condition. The objective of using this nebulization of aerosol of DNA ACE would be to decrease the mucus viscosity, because see, the DNA which is present there in the mucus is gonna increase or make the mucus very sticky and viscid. At this moment, I want to say that every time there's a fight between bacteria and the security system, some bacteria will die, some security system will die, and that means neutrophils are dying. And if the security system neutrophils will die, their nucleus will be having DNA, and that DNA strands would be having, that would produce a very thick mucus. So aerosol of DNA ACE would be used, and lots of time in India, because we don't have it, we might be using NSE, that is N-acetylcysteine. I mean, you would have written NSE to your post-COVID patients if they're having very tenacious lung secretions. In COPD patients also, you would have written N-acetylcysteine. So we can either use NSE or we can use the aerosol of DNA ACE. And along with that, another good approach would be to use nebulization of hypertonic saline. Now, the hypertonic saline that we're gonna use there can be up to 7%, and because it is hypertonic, it will suck water. And again, I want to reduce the tenaciousness. I want to reduce the viscosity of the lung secretion so that they can be cuffed out. Because if there is gonna be insipidation of lung secretions, then there is gonna be higher incidence of pneumonia. Along with this, like in Western countries, they would be doing on a weekly basis, sometimes in children with cystic fibrosis, they'll be doing weekly nebulization with tobramycin. And the advantage of this is to reduce the colonization of the airways by especially that mucoid form of Pseudomonas aeruginosa that I was describing to you. We can be either using tobramycin nebulization, or we can be using aztreonam nebulization, dry powder, which would be given in the form of a nebulization. And the advantage of that would be that the colonization of the airways will be reduced. But if there is an exacerbation and there is going to be a pneumonia episode developing, then we will have to give IV antibiotics to these patients. We will be doing a sputum culture, and usually before the sputum culture report will come, we will be giving a combination of aminoglycosides and beta-lactam to these patients. Once the sputum culture report is available, we will have to change it to the most appropriate antibiotic. Along with that, chest physiotherapy obviously plays a role. Chest percussion devices will play a role. Incentive spirometry will play a role. So we need to keep the motivation level of the patient up, so that because these children would be sick on a repetitive basis, and in America, obviously with good medical care, they'll go into adult age group as well. Then lots of time in these patients, there can be colonization of airways by even Burkholderia cepacia. Now, he knows that you will answer Pseudomonas aeruginosa as a cause of recurrent pneumonia. So there was a question in the exam in the previous years where Pseudomonas was not in the options. If Pseudomonas is not in options for recurrent pneumonia, then the answer should be given as Burkholderia cepacia. For Burkholderia cepacia, he can ask you about antibiotics also. So your first antibiotic that we can be using is simple, that Septran, that is cotrimoxazole, or we can be using meropenem. In fact, we have multiple antibiotics available, but then two important antibiotics for Burkholderia cepacia that you should know are cotrimoxazole and meropenem. A large number of patients of cystic fibrosis can develop ABPA, that is allergic bronchopulmonary aspergilloma, where they can develop lung colonization with Aspergillus fumigatus. For management of ABPA, we have to use steroids. So you can understand a difficult situation I am in, because in a cystic fibrosis patient, if there is allergic bronchopulmonary aspergilloma, there is already infection, and I'm giving steroids to the patient. So that's a difficult thing to handle. But anyway, you have to remember this: allergic bronchopulmonary aspergilloma is colonization of airways with Aspergillus fumigatus. We will have to use antifungal drugs here also, like itraconazole, but even steroids have to be used, and that would be a difficult case to handle. Overall, to summarize this topic, I can just mention a quick mnemonic by the name of APC DEFI, and that would be total of 7 alphabets. So just do a quick recap here. This is autosomal recessive condition. MCQ wise, he'll not write autosomal recessive, he will write consanguineous marriage. Then the problem with this consanguineous marriage is that children who are born are dying. And why they are dying is because they are having recurrent pneumonia episodes, which can be so extensive that these patients in future can end up with development of bronchiectasis. The meaning of the word bronchiectasis would be destruction and dilatation of the large airways, which can result in development of features like even clubbing in these patients. But for C, I'm not mentioning clubbing. I'm mainly mentioning that the chloride in the sweat in these patients would be elevated, and that is one of the tests that would help in diagnosis of this condition. Then alphabet D would be for diabetes mellitus. That's the easier part. As I explained, endocrine component of pancreas is damaged. Exocrine is anyway involved, and even the exocrine component would be affected. And because the exocrine component is affected, therefore pancreatic amylase and lipase both would be hampered. And because lipase is not there, therefore there would be fat malabsorption. Because of this fat malabsorption, he might write features of vitamin A, D, E, and K deficiency. Vitamin A deficiency, is night blindness in a child. D would be osteomalacia. E would cause hemolytic anemia, acanthocytes, and K would cause bleeding manifestations. Then alphabet I for this case would be infertility, which is predominantly a feature in male patients and can be present yes minus in female patients. In Kaltenegger syndrome, as I've explained, there is manifestation of dextrocardia. I mean, I have Kaltenegger syndrome. All I can say is, just to complete this topic, that Kaltenegger is what you study in physiology also. There, the problem is with respect to cilia motility. But in this condition, it is mucociliary clearance. Get the words right. And mucociliary clearance is primarily because of the fact that in this condition, there is gonna be dehydration of the mucociliary fluid due to impairment of CFTR proteins function, which could be due to less expression. It could be complete absence of expression. It could be defective expression. It could be misfolded proteins in the various categories that I explained to you. And then Kaltenegger syndrome will always talk about recurrent pneumonia as well as sinusitis, but we'll also talk about situs inversus, that is dextrocardia. So as such, I don't think so there is any reason apart from recurrent pneumonia. Everything else that I have described is not gonna ever be mixed with Kaltenegger syndrome, where there's a dynein arm that would be affected. And then, as I explained in this condition, the opening line was chromosome 7 defect, the total 7 alphabets that are present in this mnemonic APCDFI. And this is just a quick hack to remember or revise the manifestations of the disease that I explained before you. So this was the first video in pulmonology. You will subsequently listen to even more atypical data aspects like pulmonary embolism, fat embolism. I mean, there again, topics which are given in respiratory system towards the end, and they are the ones which are being more frequently asked in the exam. So I'm just trying to give justification to the fact that I get messages from a lot of young doctors saying, sir, in respi we traditionally read pneumonia and pleural effusion and pneumothorax, and you started with this a very atypical topic. It's based on exams, guys. It's based on the importance of topics. I mean, the sequence that I put up in these videos, I would like you to kindly respect them and follow them, and not follow your own instinct of going through those videos by yourself just randomly koi sa bhi. Is because I have put them in an order with respect to the information that I want to give you. And this is based on my experience of teaching doctors for so many years, where I've seen like, okay, what are the neglected ones where people make mistakes. So yes, guys, you're doing a great thing by doing this unit, and yep, keep hammering, keep the pressure on, and you'll break on to the other side.